Good evening to one and all. The life of a medical student is amazing, like beautiful pieces sequentially arranged. First, we learn the normalcy, then the possible abnormalcy that could occur, and finally, how to tackle this abnormality and restore normalcy. But upon completing all of these pieces of knowledge need to be arranged together like pieces of a jigsaw puzzle to finally attain a beautiful picture reflected through our clinical practice. So let us continue into the second day of Sastrasiddhi, National Webinar on Salyatantra, a dais to explore the theoretical and practical utility of Salyatantra. First, I invite our student Devika Rajan for the prayer. Devika.
Hello, ma'am.
Yes.
संसार समुद्रतार नौकायिताभ्यां गुरुभक्तिदाभ्यां वैराग्य साम्राज्यत पूजनाभ्यां नमो नमः श्रीगुरुपादुकाभ्याम् कवित्ववाराशि निशाकराभ्यां दौर्भाग्यदावाम्बुद मालिकाभ्यां दूरीकृतानम्र विभक्तिदाभ्यां नमो नमः श्रीगुरुपादुकाभ्याम् नदाययो श्रीपतितां समीयु कदाचिदप्याशु दरिद्रवर्या मूकाश्च वाचस्पतितां हिताभ्यां नमो नमः श्रीगुरुपादुकाभ्याम्. Thank you.
Thank you, Devika. Next, I invite our student Shruti P for the welcome speech. Shruti.
Hello, ma'am. Hello, ma'am. Am I audible?
Yes, you are. Speak.
Honorable resource person, respected teachers, organizing committee, delegates, and my dear friends, a very warm good evening to one and all. I consider it as my immense pleasure to have been asked to propose a welcome speech on the second session of Sastrasiddhi 2020 on putting up an anorectal clinic organized by the Department of Salyatantra, Ashtamgam Vidyapeedham and Chikitsalayam. So let me move on to my duty. I, on the behalf of Ashtamgam Vidyapeedham, extends a very hearty welcome to our resource person, Dr. T. Sreekumar Sir, HOD and PG Dean, Department of Salyatantra, PNNM Ayurveda College. I also welcome our beloved teachers of Salyatantra Department, Dr. Purushottaman Nambudiri Sir, HOD, Salyatantra Department, and Dr. Jolsna Govindan Ma'am, Assistant Professor, Department of Salyatantra. Next, I would like to welcome Dr. Rahul Sir, HOD, Department of Roga Nidhanam and Vigarthi Vijnana. Last but not the least, I welcome all delegates and my dear friends to this session of Sastrasiddhi 2020. Thank you, ma'am.
Thank you, Shruti. Next, I invite Dr. Rahul R. Nair, HOD, Roganidhana and Vigarthi Vijnanam Department, to kindly speak a few words. Sir. Rahul, sir.
Am I audible? Jyotsna, am I audible?
Yes, sir. Yes, sir. Yes, sir. You are.
Respected Dr. Sreekumar sir, Purushottaman sir, Dr. Jolsna, my dear students, and all other participants in this national webinar. First of all, let me thank you all, and especially Dr. Jolsna and Dr. Purushottaman sir for giving me this wonderful opportunity to felicitate none other than Dr. Sreekumar sir. For members of our profession, Dr. Sreekumar sir, who is very fondly called often by these students are as Dr. TSK sir, needs no introduction at all. But as all of you know, we used to call Sir as an all-rounder. Why? Because he's a great surgeon, very precisely working person. He is running a very proficient hospital in Thrissur for past, I think, for more than 30 years, which is specializing in anorectal diseases. And more than that, he has contributed a great literary service by commenting on Ashtamgam Vidyapeedham as well as on Charakam. And what I feel that when thinking about Sreekumar sir, I just go back to my student days when, as a first MD scholar, I one fine day reached his hospital and I briefed him about my synopsis, PG synopsis, and he had taken the enough pain and hard work. He told me that you should visit me after 1 week, and when I get back to him after 1 week, he had made an excellent backup for my work, and he has discussed me in length and breadth regarding the possibilities of exploring the Arshoroga in all its wide perspective. And I still remember he is sitting with me, correcting even my title of the dissertation, and I had used that title for my PG synopsis, PG thesis. So, as a teacher, he has been in Ullur Ayurveda College, and sir had given wonderful contribution in building up a very fine department. I think it is the finest department of Kriya Shariram in Kerala. And from that, he joined now his own territory, his own terrain, Salyatantram at PNM Ayurveda College. And we used to discuss with my colleagues at PNM Ayurveda College, and they say that Sir is the most hardworking person in the department. So it's very fine moment now that we got the opportunity to hear the words regarding how to set up an anorectal clinic from a person who is an accomplished clinician and accomplished surgeon who has been practicing meticulously for years. And for that, for coming here, speaking to our students and inspiring them, I am really grateful to Sreekumar sir. Sir, I wish you all the very best, and also I wish all the participants in this program that they can utilize the words of sir in all its essence and in all its true spirits, and they can all set up good clinics in future and become great clinicians. Thank you, sir. Thank you one again. One and all.
Thank you very much, sir. A visionary in Ayurveda who has definitely created a niche for himself in Salyatantra, Dr. T. Sreekumar needs no introduction. A dignified teacher and a diligently skillful clinician, he is an inspiration to all. A recipient of the prestigious Atre Award for the Best Doctor in 2011, an award bestowed by the Kerala government for the best teacher in Ayurveda colleges, Dr. Sreekumar is also renowned for his literary contributions to Ayurveda, touching almost all the spectrum of our science. Today, he will be dealing with the topic putting up an anorectal clinic, a topic which is very much relevant to the times. So without much further ado, sir, myself, Dr. Jyotsna Govindan, Assistant Professor, Department of Salyatantra. On behalf of Salyatantra Department and Ashtangam, would wholeheartedly like to invite you and humbly request you to begin your session. But just before starting the session, a few points to be noted will be displayed on the screen. Please go through them. These are a few guidelines which could be noted during the session to avoid unwanted interruptions. All questions to be posted in the chat, and once the class is over, we'll be going through them and asking stuff. You can please switch off your audio and video so that you do not disturb during the session. And in case of any disruption, kindly check your internet connection and patiently wait for the class to resume. And also, another notice is that a feedback form will be made available in the chat box after a while, which will be seen as a link in the chat box. All the participants who have participated in at least 3 of the sessions and who have duly filled and sent the feedback forms will be provided with an e-certificate of participation. Respected sir, you may please begin your session. Sir?
Hello?
Yes, sir. Please to start, sir.
I have to start now, no?
Yes, sir. Yes, sir. You may start, sir.
Okay. Now, first of all, let me extend my thanks to Ashtamgam Vidyapeedham as well as the HOD of Salyatantra, Professor Purushothaman Nambudiri, and all the others who have showered good terms about me. Let me start my topic. Opening upon Anorectal Clinic. See, why I have selected upon this topic out of all the topics of Salyatantra is that Dr. Purushothaman told me that this presentation and this class and this seminar is basically targeted at fresh graduates who have just finished their graduation and house surgeons also. So what I am aiming is that those whoever have just passed out Ayurveda college and who is beginning to wonder what am I to do after my graduation or after my post graduation, where shall I go for a post graduation? Is Kaichigulsa better, Shalya better, Chalakya better, Prasuti better? So many questions will be raised. So standing upon the pedestals of Shalyatantra, what I have to tell is that I'm not telling that Shalya is superior, Kaichigulsa is superior like that. Shalya has got definitely its own options. I know perfectly well that many people who have post-graduated Shalyatantra are simply sitting idle. They are not at all entering into the professional arena. And there are, of course, streams like Shalakya, Kaichigulsa, Panchakarma, etc. also, who have just passed and they are as if they are waiting for a job. What I am telling you is that why don't you begin your own clinic? That was what I did around 33 years ago by opening up an anorectal clinic. At that time, I'm not telling that I'm a yeoman in the field or I'm a Apurva Vidya in this field, nothing like that. But what I am telling is that urge should be there, that you can do something. Only if that urge is there. Of course, there may be complications also because you have to be there attending the cases day in and day out. If at all patients call you around 12 midnight, you have to go to them. Doctor, there is a bleeding. You have to go there. You have to arrest that bleeding. Doctor, there is severe pain. You have to do something about reduction of pain. Whenever you are invited by the patient, that is your cardinal responsibility. Freedom will be less. Yes, there are so many drawbacks. But at the end of the road, you can see that you will be one of the toppers who have done something for the society at large, who have done something to your science at large, who have done something for your speciality at large. That greatness will be there. That is why I am inviting the freshers in the field to Shalyatantra. And after getting a post-graduation in Shalyatantra, maybe to open up an anorectal clinic themselves, of which I am going to talk to you right now. I think I am audible to you. Hena, am I
Yes,
audible
sir.
to you?
Yes, sir.
Yeah.
Yes, sir. You.
Thank you. The contents of this presentation are, number one, the relevance of anorectal clinics, the prerequisites. You may not like when I am telling about the prerequisites, but the prerequisites of starting an anorectal clinic, the essentials that you should have, the issues faced. Wherever you go, there will be issues. Here also issues will be there. And how to overcome these issues. And last but not least, certain tips and certain messages from my part. These all are the contents of this presentation. The relevance of anorectal clinics means this is a great opportunity because diseases of anorectum are historically given due importance in all medical systems. In Ayurveda, we all know Harsharoga is considered to be a Maharoga in Ayurveda. Not only Arshas, when it comes to fistula in Anu, Bhagandara is much more a serious condition than Arsharoga. So, almost all the diseases pertaining to the anorectum and to the pertaining to the colon also. Colon itself is considered to be as an important organ. You all know, I need not tell you that it is an important organ for Vata, important site for Vata. So, and the diseases in that premises, not only anorectum, but the intrapelvic region are considered to be somewhat of a higher nature. Due importance was given. And almost in all the other medical systems also, allopathy, homeopathy, everywhere, these diseases are given a special privilege over the other diseases. And not only that, these times see more and more anorectal cases, thanks to maybe the rational food style which are being followed and the toxic elements which you are consuming along with food, the fried food that you are consuming, whatnot, the liquids like Coca-Cola and other hydrogenated beverages that you are consuming. I don't know how much importance all these have into the genesis of the diseases of the anorectum. Definitely, you all know that there is an edge for these food habits to cause these diseases. And current allopathic management for these disorders have many drawbacks. We have seen, we are seeing daily. Despite the advancements made in allopathy, not only in medicines, not only in diagnosis, but also in specialized surgical techniques, allopathic parlance have made immense improvements. Even then, the current allopathic management for these disorders have many drawbacks. Whereas starting and maintaining a good anorectal clinic of good standard I'll call gold standard, would further our science and further ourselves also. There is a certain uniqueness for every anorectal clinic. Every anorectal clinic means, I'll come to that point later onwards. Kerala has not got much anorectal clinics. Whichever Ayurveda anorectal clinics are there in Ayurvedic parlance, almost 90-95% of these anorectal clinics are attached to some teaching hospitals, Ayurveda hospitals. In the private field, it is like seasonal. A new anorectal clinic will come and then gradually after 3, 4, 5 months or 1 year, it will be closed. God knows why. Continuous practice in an anorectal clinic for years together, I don't know why it is not successful. There are many reasons. We'll come to that reason. Anyway, the number one unique point of anorectal clinic is that it is not just a specialization, it's a super specialization. And it is a rare clinic because not many doctors are there in the field. Of course, as I have told previously, there are many who have passed out Shalyatantra, but there are not many doctors who are practicing in anorectal clinics continuously for years together. And then about anorectal clinic, one more point is that patients want privacy. Privacy does not depend upon male-female privacy alone. Personal care they want, means one-to-one attention. And anorectal clinics demands constant surveillance. As I have previously told, bleeding, pain, so many drawbacks are there. So you have to be constantly vigilant when you are conducting an anorectal clinic. Demands constant updation of knowledge also. See, I don't know how many of you know that I have finished my post-graduation in 1985, 85, 86, 85 itself, 85 December to be precise. Long 35 years ago. The knowledge that I had at that time, if I was using that knowledge alone, it would have been very difficult because 35 years means so many things have happened in the world. So many water have drained through the Ganges. Updation should be there. Every day. Updation means every day, not every year. Every day you should update your knowledge itself. Not only in modern aspect, but even in Ayurveda. Theoretical knowledge as well as practical knowledge. What is the new protocol for management of fistula in ano? What is the new protocol for management of fissure in ano? Like that. And you should incorporate, you should imbibe, you should welcome all the latest advances in the field. By that, you can serve the humanity from diseases very difficult to cure. That passion should be there. It is a virtuous profession. It's a holy profession. And it's an auspicious profession. Anorectal clinics can be used for diagnosis and management of hemorrhoids, fistula in ano, fissure in ano. See, these three things, these three conditions commonly come to us. Not only these three conditions, in the disguise of fistula in ano, many cases of hidradenitis suppurativa also comes. I think that fresh graduates know what is meant by hidradenitis suppurativa. Each part of the term has got its own meaning. Hydra, adena, and itis. Suppurativa. Then pylonodal sinus and mammary sinus also in females. Then perianal abscesses, usurectal abscesses, and even cancers of the rectum and anus. At least the diagnostic part we shall be confident of. So these are the general conditions which can be managed in anorectal clinic. Apart from these conditions, it's theatre, the anorectal, because we ought to construct a theatre for anorectal clinic. It's a private area. And this theatre can be furthered, extended. The use of these theatres can be extended for Agnikarma, Reptamoksha by Siddhavetha, Jaloga, Shringa, etc. etc. Very less qualified doctors of any medical system are conducting anorectal clinics worldwide, especially in India and especially in Kerala. However, the bad thing about this thing is that very common by quacks. Quacks conduct a lot of anorectal clinics. Even in Kerala, even in Thrissur, if you go from here to your college, from Thrissur to your college, you can see at least half a dozen boards claiming that they are curing piles, fistula, fissure, etc. At the same time, it's very difficult for you to see a board or something like that claiming that this is a hospital for anorectal disorders. No, there is no such thing. But plenty of quackery clinics are there, run chiefly by Bengalis. However, so-called Bengalis, because they may be Bengalis or they may not be Bengalis. However, anorectal clinics are comparatively less in Kerala, but common in metropolis like Bombay. The influx of quackery in the field is maybe particularly because law alone cannot control the influx. There are so many other factors. Of course, law should be strict and adamant, but law alone cannot control the influx. Qualified practitioners can't do the procedure at the fluctuating rates of quacks. Because if you go to a quack person and tell that you have got piles, suppose you are going by wearing a lungi, the rate they will be telling will be some 1000 or 2000 rupees. But if the same yourself go to them wearing a pants and shirt and everything, the rate may jump to some 10,000 or 15,000 or maybe more than that. So the fluctuating rates of quacks cannot be maintained by qualified practitioners. And I need not tell you, because you are all in the medical profession, that many are the dangers of quackery. They are said to be using a certain types of thread. We are also using a thread, but we are using Charasotra. It is said that those people are using a thread of made dipped in some nitric acid or sulfuric acid or things like that. We don't know. We have not seen. It is said that it is acidic thread. We are using alkaline thread. They need not know any anatomy, no physiology, and no medical legal considerations also. Because if something happens to the patient, the next day when you go there, nobody will be there. There will be no board even. They would have just escaped to some other fertile land. Many of them haven't qualified primary level of education also. Quacks are fleeting practitioners,
Excuse me,
ignorant of
sir.
social norms. So they need not bother about medical qualification or registration or anything like that.
Excuse me, sir. Sreekumar,
Yes,
sir.
yes.
Sir, I believe the slides are not visible, sir.
Slides are not visible.
Oh, sir.
Why so?
Could you just share it once again, sir?
Okay. You cannot see the slides now.
No, sir. Not yet, sir.
I'll close it and I'll open it once more.
Yes, sir.
Now can you see it?
No, sir. Not yet, sir.
Oh, something has happened. I don't know why.
Excuse me, sir. Sir, you have to place it in the presentation mode, sir. The slides.
Presentation mode means where shall I go?
The bottom right corner, sir. There is a slide presentation mode is there.
Screen
Then you
is
have to
there.
take.
Screen is
Share
there.
the screen, sir.
Share your screen. Yeah.
Sir.
Now can you see?
No, sir.
No, sir.
Now also you
Sir,
cannot
first you
see.
have to open the slide, sir. Keep it open, sir.
Slide is open.
And it should be in the presentation, the presentation mode, sir. The slide should be in the presentation mode.
It's already shared.
So there will be a screen in that presentation, the PPT screen, right corner. There's like a TV screen. That's you can see a TV emblem, right bottom corner in that PPT screen. PPT screen, right, one television picture will be there.
Slideshow mode.
Yes, yes,
Now you can see, no?
yeah.
Okay. If there is any problem in between, you can always ask me. So you have not seen these slides?
Okay, sir. Thank you.
Okay, so all these slides are over. Shall I go through it once more?
No, sir, you could.
Hello?
I think you could continue, sir. You could continue, sir. I think everyone has got the grasp of it.
Okay. So this was what I was talking about. Why quacks are prevalent in our society? Maybe because of absence of strict laws, maybe because of absence of implementation of existing laws, or fluctuating fees, or basically ignorance of society. What are it be? Let us come to our point. The prerequisites of starting an anorectal clinic are number two in number, basically. Number one, of course, is knowledge. Knowledge means in-depth understanding and constant updating, as I have previously told. In-depth understanding should be there, and constant updating should be there. And practice, constant practice. If you are able to manage 100 cases of piles, manage 100 cases, the 101th case will be, you will be managing differently, maybe. So, practice and practice and practice. Practice makes man perfect, and practice also makes women perfect. The best of theory and practice you have to harness. That is one of the second prerequisites of starting an anorectal clinic. Better in one's own premises. If you are starting your anorectal clinic in some rented building, after some so the dreams that you have built up all will be destroyed. So better to in one's own premises. The locality, your theater, the facilities for referral. If you cannot manage a particular case, referring those cases to some good nearby institutions, all those should be there. And there should be your supporting team of staff, and at least minimal IP facility should be there. Daily dressing you have to do. Morning and evening daily dressing you have to do. Means I am doing. Many people who are conducting anorectal clinics in many institutions also, patients are advised to come weekly once or once in 2 weeks. Whereas I basically ask the patient if it is a fistula case to come daily for dressing. That is vital. Otherwise, you may not know whether some infection has occurred or some complication has occurred. So daily monitoring the case is vital. And proper planning should be there. What is the first step of treatment you have to do? What is the next step? When shall I change the thread? When shall I tighten the thread? What thread shall I use? What all other medicines shall I use? All these things. What are other medicines shall I give internally? For all these things, proper planning should be there. And that planning should be implemented properly. Knowledge of our strength is very good. It's a good thing. At the same time, knowledge of our weakness is more stronger, makes you more stronger. Knowledge of strength and comparing knowledge of strength, our own strength, and our own weakness. Knowledge of our own weakness is more important than knowledge of our strength, what I feel. At the same time, belief in ourselves make you confident to do your work. Drishtakarma. Why I have put this slide is that many people are of the impression that anorectal diseases can be studied by a 2-day, 3-day course like that. They will see some cases and they will manage like that. What will happen is that these people will be Drishtakarma individuals only. You should, at the same time, the essential meaning of Drishtakarma means you have to see, you have to attend, you have to ask your guru questions, all these things. Then at the end you will be becoming a Drishtakarma. Drishtakarma means seeing is believing. You have to do and you have to study, you have to build up images in your brain, and then you can imagine that this has to be done not like this has to be done like that. So this is the basic Drishtakarma. At the same time, certain people think that Drishtakarma means just seeing and I can do everything. It's not like that. You must observe, you must assist, you must manage with assistance, and you must manage independently. And you must, as I myself have previously told, you must embrace all the advances in the field. You must think and be ready for relinquishing the bad and accepting the good. While while I am managing this case with this particular medicine, this complication has occurred. So that medicine is removed from our screen and let another medicine come. Like that. You must be ready to relinquish the bad and accept the good, and you must achieve proficiency within time. See, this is the benefit of actual Drishtakarma. At the same time, if you have got an Ekalavya strategy, what is meant by Ekalavya strategy? There is no guru, nothing like that. You are observing here and there, something like that, that's all. It is not, it also is not the original Ekalavya, which is the Ekalavya of Mahabharata, we all know. The original Ekalavya of Mahabharata had a guru. The guru was in his mind. He was not in the mind of his guru. But to him, that guru was always with him. And he studied and studied and studied and studied and studied until finally he became greater than Arjuna. At the same time, this will not happen in most of the cases. This will sometimes work if you have a blind faith in your guru. Nobody can successfully run a clinic for long by qualification alone or attending a short time course. One should evolve fresh strategies in each case and imbibe advancements in the science by incorporating all the latest technologies. What I feel is that the best strategy is to think deep. When you are doing, see, the techniques what I am doing now, nobody has taught me. In that perspective, you can call me Ekalavya, because each of us are Ekalavyas when we come to that point. Means it is not we have studied, we have learnt in the institution that we will practice after 5 years or 10 years or 20 years. It will be extremely difficult and different. I didn't know. I hadn't even heard of what Barron's technique was what rubber banding ligation was when I was doing my post graduation. Such a technique was not there at that time. I think we hadn't heard about it. Such techniques. We had heard about Charasutra and about the various operative procedures in hemorrhoids, all these things we knew, but we never had heard about all the lasers and other techniques. We never had heard about what we are using right now. So the best strategy is to think deep. What am I to do in such cases? Where have I gone wrong? All such cases, all such things we have to think and think and think into the depth of it. We have to imagine. We have to find out the parallels. They are doing like this. Allopathic people are doing like this. Anyway, we cannot do that thing. So what we can do, like that, bringing forth parallels and bringing forth hypotheses and test existing concepts. Is it correct? Is lateral sphincterotomy the most effective thing in management of fissure in nano? Why it is like that? What is lateral sphincterotomy? What they are doing by lateral sphincterotomy? What they are cutting? Which sphincter they are cutting? If they are cutting the internal sphincter, would not other complications occur? You have to think and think and think, and then you have to do, and then you will be at last. God will give you opening through a door, and you can see wonderfully. You can see that this is a new concept is for your disposal. You have to implement them and objectively assess and publish findings periodically. See, this is the strategy what I have to give you. Knowledge is a must factor. There is no doubt about it. Knowledge, knowledge, and knowledge. Must factor. At the same time, wisdom is a key factor. It's not knowledge which is a key factor. Knowledge is only a must factor. Wisdom is a key factor. Hello?
ഹലോ അത് കുറെ നേരം ഇറങ്ങിയിട്ട് ആ സാധനം
ഇല്ല
Hello?
ഇപ്പൊ ഒരു 6-7 മിനിറ്റ് ആയുള്ളൂ മിനിമം.
Hello? You cannot see it? Hello?
Really sorry for the interruption, sir.
You cannot see the slides?
No, sir, it's
Hello, I
quite
cannot
clear.
understand what has gone wrong there.
We can see, sir.
You can see and you can hear me.
Yes, sir. Yes, sir. Please do continue.
Okay. So there is no problem now.
No, sir.
Okay. So knowledge is a must factor and wisdom is a key factor. Knowledge means anatomical knowledge should be there. I'll come to the anatomical knowledge part. Anatomical knowledge should be there. Physiological knowledge should be there. It's not that you are a surgeon and you need not know anything about physiology. Knowledge of physiology is a must. Pathological knowledge should be there. Applied knowledge of all these things should be there. Anatomical, physiological, and pathological aspects. Applied knowledge, applied anatomy, applied physiology, applied pathology. All these things you should know. And knowledge of management of all systems should be there. Don't think that I am an Ayurvedic individual and I need not know anything about other systems. It's not like that. You have to know about all the other systems. Each and every other system, what they are giving, what they are managing, what type of surgery they are doing. Ekam shastram adhiyano na vidyat shastra nishchayam tasmat bahushruta shastra vijaniya chikitsaka. Sushruta has put it categorically. The knowledge of the current medical system and classical medical system also you should have. And it is not like knowledge only. Its application should be there. Application of knowledge should be there. And if you apply that knowledge, what type of complications can be there? Knowledge about complications should also be there. And how to manage those complications also should be there. So anatomical knowledge, pathological knowledge, physiological knowledge, applied knowledge. Knowledge of management of all the systems, current and classical. Application of knowledge. Knowledge of complications and knowledge of how to manage such complications. All such knowledges together put is called as wisdom. And behavior is also important. I need not tell you. All of you know. Regarding behavior, Ashtanga Hridaya Vagbhara has given the a gist about how to behave in the society, especially with patients. Janasya ashayam alakshya yo yadha paridushyati tam tadhaiva anuvarteda pararadhana pandita. Very easy. How will you become happy? If you become happy by behaving to you in a good manner, why not why not your behavior should be changed so as to suit the society? So janasya ashayam alakshya yo yatha paridushyati tam tadhaiva anuvarteda pararadhana pandita. Not only that, other things are also there. I'm not going into the depth of it. All these things. If a poor person come, suppose your rate is X, you should not tell them that your rate is X, whereas you can treat them free of charge if the patient is avrutti vyadhi shogartan anuvarteda shaktitaha. According to your capacity, you can give concessions to him. Vimukhan na arthina kuryad. No, I'm not doing that like that. It's not like that. You can help them. As much as you can help them, you should help them. Vimukhan na arthina kuryad, na avamanyeda, na akshiped, upagara pradhana syad, apagara parepyarau. All these things are mentioned. I am not going into the details of it. Patient complaint versus reality. See, many are the people, many are the doctors, not only in Ayurveda, but in all the systems of medicine, who manage based on complaints, not upon reality. Bleeding per rectum may be the presentation of a patient. Bleeding per rectum, you are having bleeding per rectum now, BPR. So you should be having hemorrhoids. You take these medicines like that. It's not like that. You should examine the case. Because bleeding per rectum need not always be due to piles. It may be due to fissure, or even it may be due to cancers. Pus discharge need not always be due to fistula. When it comes to pus discharge, you might have a contention that it is due to fistula. It may be due to fistula, but it may be also due to hidradenitis, tuberculosis, etc. Pain, severe pain. Severe pain, anal pain is there. It may be because of fissure in ano. It may be because of fissure in ano, but it need not be due to fissure in ano alone. It may be due to thrombosed piles, infected piles, or even cancers. So what I am telling is that patient's complaints are one thing, whereas reality may be different thing. So the difference between the complaints and the reality you have to gauge. History taking when it comes to diabetes, many patients nowadays especially will be diabetics. Almost 50% of those who have passed 50 years of age will be having diabetes. And hypertension, coronary artery disease, dyslipidemia. No. All these things are not mentioned in Ayurveda. I'm not going to check all these things you may be telling. It's not like that. You should go and take history about all these things. And you should also take history about whatever surgical procedures have been done, whatever are the adverse drug reactions the patient has encountered before. Is there any family references or occupational references which are related to the disease? And objectivity of assessment, objectivity, all these things should be part and parcel of the taking a history, because taking history is an art. It is a science at one edge, but it is also an art. You should spend time and you should spend your effort upon taking history, because taking history will give you it is a gold mine of information concerning that particular individual. Do you smoke? Do you drink occasionally? What are your habits when you will get up, when you will go to bed? What all type of food you are taking? Is there anybody in your family who are affected with the same complaint or similar complaint? All these things. Gradually, you have to enter the mind of the patient and take all the precious stones out from the mind of the patient. Then only you will be getting proper diagnosis. Ask sympathetically. Disclosure depends upon belief in you. When you are asking, what all are your complaints? Like that, the patient may not be able to tell you. So you have to ask the patient sympathetically to get a disclosure upon the various complaints and various historical aspects the patient had regarding the disease. The patient should feel that you are helping them rather than you are writing down what the patient is telling. They should have the feeling that you are their brother or sister or somebody like that. That you are their kith and ken, like that. Then only the patients will reveal everything they have to tell. Even matter of seemingly insignificant thing may prove of highest significance later onwards. Examination of the patient is a must. By simply hearing upon the complaints, if you are going to write the medicines about an anorectal disease, it is totally unjustifiable. Even in these days of COVID, even in these COVIDian days, I will tell you that you have to examine an anorectal patient. Otherwise, you should not prescribe anything, because it is dangerous. See, last 1 month itself, last 35 days itself, I have got 5 cases of colorectal cancer. Would you believe? 5 cases of colorectal cancer. These 5 cases have gone here, there, and everywhere. And all those people, including allopathy, Ayurveda, homeopathy, everybody were writing medicines simply. They haven't examined the case. When we examine, to our surprise, we can get something there, some masses there, some hard masses there. Okay. Then we will have to take biopsy. Then we will have to send for histopathological examination. And after histopathological examination, adenocarcinoma, squamous cell carcinoma, like that. So never leave a patient, never give a prescription to a patient without proper examination. It is a must. Local examination should be done. Systemic examination should be done because weight loss is there, anemia is there, and other complaints are there. All the relevant investigations. It is not that all the investigations you should do. All the relevant investigations you should do. Which all investigations are accurately relevant. If MRI is relevant, if it is relevant, then only you do, because MRI costs anything like 10,000 rupees or 12,000 rupees. Unnecessarily, you should not tell the patient that you have to do this procedure, this investigation. But if it is relevant in the management of the case, then you should definitely do it. You should demark the patients unfit for the procedure also. If the patient is highly diabetic, you should not manage the patient before making his blood sugar normal, like that. I have just given you example, that's all. These are all the positions for rectal examination. All the doctors know, all the fresh doctors know about Sims position, number 1, which is mentioned in our own text as the position for Vastikarma, almost similar. Sims, this is also called as the left lateral position, but in left lateral position, both the limbs will be folded, but in original Vasti position, the left leg will be straightened. Sims position can be done in the right side or left side, both sides, but in the classical Vasti position is left-sided. That's all the primary difference between Sims position and our Vasti position. Then there is a jackknife position, then lithotomy position, in which we all means almost the entire Ayurvedic field of doctors, Salyatantra specialists from Trivandrum to Banaras Hindu University, everybody are using the lithotomy position. Then if you have not got the space in your clinic or anorectal theater, you can even examine the patient standing. And then the knee chest position is there. Knee chest position is a modification of a lithotomy position. Where there is no lithotomy table, you can examine the case in knee chest position. And in certain cases, when you have to take a biopsy from the posterior aspect of the rectum, where it is very difficult to take biopsy when the patient is positioned in the lithotomy position, you should position the patient just the ulta, by knee and elbow position, where the posterior rectum will be free, the anterior part of the rectum will be hanging, so that any masses or anything like that there can be seen. And if you want to take a biopsy, then also you can do it in the knee and elbow position. Knee and elbow position is also a urologic position for passing out urine. If the neck of the bladder is obstructed by a stone, you simply ask the patient to be in the knee and elbow position, so that the stone will tilt backward, so that the urine can be passed very easily. So all these positions are there. I think you all know about all these positions. You might have learned it in your degree level. Then it is not the positions alone which are important. When you are inserting your finger, or when you are inserting the proctoscope into the patient's rectum in a particular position, you should know the surrounding anatomy, the related anatomy of that area, in the male and in the female. In the male, you know that the prostate is there anterior to the rectum, so that you can even do a prostatic massage there in where if needed. And you can examine the bladder through the prostate. When you are lifting the prostate, the bladder also will be lifted to a certain extent, like that. All that anatomy, the related anatomy also. Posteriorly, the sacrum is there, That anatomy also you should know. And in the female there are so many organs like the ovaries, the uterus, the fallopian tubes, etc. The gynecological apparatus, so called. In addition to the bladder, the urethra, which is very short in the females, and the cervix will come. And in certain individuals, the cervix uterus will be very larger, so that you may think initially that there is a lump over there, if you haven't examined for so many cases, and all those things. So the anatomy and the related anatomy you have to know. Not only that, the microanatomy of the anus, rectum, and colon also you should know. Microanatomy for assessment of the type of fistula in ano and the likely complications that would have in the event of a fistula in ano. You have to know the applied microanatomy of that region. Where is the levator ani muscle placed? Where is the squamous mucosa placed? Where is how many types of mucosa is there? All these things. The pectinate line, the anorectal ridge, the anal canal, the structures in the anal canal, the keratinized squamous mucosa, and the neoplasms that may occur in each type of mucosa, and in the transitional zone. All these things should become clear only if the applied microanatomy is known properly. And the significance of microanatomy is more when you come to malignant growths. When you want to stage a malignant growth, you have to know the significance of microanatomy. Then there are various types of examination coaches. When you have to put up a clinic, you should know how many types of coaches are there. So many types of coaches are available, from the very simple coach which you see in the left side, that black one, to the very complex one which you see at the right side, that blue one, which has got spaces to store the essentials. Various types are there and various costs. You can get examination coaches. Certain unexpected findings can be got by local examination alone, like, for example, cancers. Oh, you expected a hemorrhoid, but what you are seeing is there is a mass there. What is this mass? Mass can be anything. Take out some scrapings from the mass, put it in formaldehyde, load it, send it for histopathological examination, wait for the results. When you get the results, you will know what type of a mass it was. And fistula and piles, fistula and fissure. See, patients will complain of fistula only, but when you examine, piles also will be there. When you examine, fissure also may be there, so that it may be a fissure fistula. And to your surprise, you may even unearth certain other diseases like Crohn's disease, ulcerative colitis, Koch's disease, that is tuberculosis, etc. So all these things are unexpected findings at local examination. Then systematic examination, if you ask the patient directly, are you diabetic? No, I don't have diabetes. Diabetes is not there in my family itself. But when you examine, the patient might have 499 blood sugar. So such unexpected findings may be got during systemic examination or investigations like diabetes, hypertension. And even when you are taking, if you are doing a procedure, before some 10 minutes to 15 minutes, we'll be taking an ECG of the case. So in some individuals, there may be alteration in the ECG or T-wave inversion when we suspect it a myocardial infarction. So CKD, IHD, and consumption of thrombolytics. Suppose the patient is consuming aspirin for years together, you should not immediately post the case for surgery, because complications like bleeding may be there. So that you have to stop the aspirin after getting permission of the doctor who has prescribed the thrombolytic. Aspirin, clopidogrel, all those things are thrombolytics medicines which has to be stopped before doing any procedure, and that sanction is to be got from the doctor who have prescribed these medicines. And then recording of findings. None of the important findings or data received should go unrecorded. documentation is necessary. Everything should be documented. If possible, whoever, in whomever you are doing the procedure, that case also, that region also should be recorded visually, means a photo should be taken. Note all the data or findings in chronological order. The case sheet should be specific for anorectal purposes. It should not be a general surgical case sheet. It should be precise but all encompassing. It may be in 1 or 2 pages, but everything should be there in those 1 or 2 pages. While taking case, I need not tell you, your mobile should be switched off and all attention should be given in the work which you are doing. Every now and then, hello, yes, okay, it should not be like that. You should concentrate yourself in the work you are doing. Then only the patient will be satisfied. There should be a sort of gentleness plus firmness in your dealing with the patients. The clinician should be, it is okay. The clinician should be gentle to the patient. What's your name? Hello? You can hear me? Hello? Hello? Can you
Yes,
hear
sir. Yes,
me?
sir. Yes, sir.
Okay.
Please.
I thought that somebody was talking to me. Okay. The clinician should be gentle to the patients. He should not succumb to the patient's demands, which are likely to interfere with diagnosis or management or ethics. No, I cannot clean that area. Nobody has cleaned that area before. So you too need not clean that area. If the patient is telling like that, we ask the patient to go home. We will not attend the patient if the patient does not satisfactorily attend to our demands for cleaning that area and examining that area. So in that case, we should be adamant and we should firm. At the same time, for all other things, we should be gentle towards the patient. So there should be a sort of gentleness plus firmness in our approaches towards the patient. And you should be honest in whatever you are telling. State frankly what you can. Can you give a guarantee that this disease will not recur? Sorry, madam, I cannot tell like that. I'll do whatever I can, but I cannot give you a guarantee. That you should state frankly, because who can give any guarantee? Who can give any guarantee for that matter that after half an hour I'll be alive or not? Nobody can give any guarantee, even to the life also. So how can you give a guarantee to the patient? The maximum what you can give, which you can do, is that you can be frank. You can be sincere in your work. That's all, the maximum. So state so frankly what you can and what you expect and what you cannot do to the patient. Don't procrastinate what you have to tell. How can I tell that to the patient? Not like that. You have to tell what you have to tell then and there. That's all. Then certain non-technical aspects are there, like where to start the clinic and locality and other things. That is one thing. When to start, the time of the work. Is it between 9 to 10 or 4 to 5, or what is the best time to start the clinic and work the clinic? All those things are non-technical aspects of which I am not going on talking. Regarding the assistants and supporting staff, the assistants, I need not tell you, the assistants and supporting staff should be loyal, should be sincere, to be up to the mark in knowledge, up to the mark in wisdom also. Then about publicity and maintaining continuity of service is maintenance of continuity of service is vital. As in the course of my previous one or the second or third slide, I was telling you that many anorectal clinics have begun in our state, but surprisingly, after 4 or 5 months or 1 or 2 years, all these clinics are closed like that. Why? Why the continuity of service is not maintained? Because it is not easy for anything to be done day in and day out, continuously, years and years and years together. After a period of time, you will feel that enough is enough, like that. Don't, if you think like that, it is the patients who will be left blindfolded. And other issues are there, of which I will not like to talk during this presentation. The technical specifications are with regards to space. Space and other things should be with regarding to the regulations in force according to good clinical practice regulations published by the Government of India. You should get a PCB sanction first of all. PCB sanction means Pollution Control Board sanction, which is not very easy. You have to shell out some lakhs in order to build the provision for getting the sanction. And then only you will be getting a panchayat or corporation license. So PCB sanction is the primary thing. Then you have to go for panchayat license or corporation license. And other certificates, of course, for reimbursement purposes. And you should get proper equipment and proper stationery. So all these things are the technical specifications. Regarding the space, you should have a patient's waiting room, the size of which depends upon the number of patients coming to you. And there should be a preparation room for preparing the patient. That area, you should have a particular space for that. You should have a male to male and female to female supporting staff. If the patient is female, you should have a supporting female staff. Patient is male, you should have a supporting male staff also. Sterilization premises should be there. An examination room should be there. And a procedure room, which is called as minor operation theater, should be there. And as in the case of myself, you can join the examination room and the procedure room together. That also can be done. Then a recovery room. After the procedure, the patient has to take rest. So a recovery room should be there. And after the recovery, if the patient is admitted, the patient has to be given admission in a particular room or an observation. The patient has to. So these types of spaces should be there. Waiting room, preparation, sterilization, examination room, procedure room, or theater, you can call it minor operation theater, recovery, and admission. All these things should be there. The regulations in force are decided by the clinical establishments rules published by the Government of India, 2019, third amendment. But the thing is that this has not come into force now. Now you can begin your clinic even without clinical establishment rules in prevalence. But tomorrow, day after tomorrow, it is certain that these rules will be implemented. And the separate rules are there for minimum standards for different categories of clinical establishments of allopathy and Ayush, like dentistry, our own Sarasutra clinics, our own Panchakarma clinics, all these things, separate regulations are there. So you have to go through these regulations before opening up a clinic yourselves. As previously told, getting a PCB sanction, Pollution Control Board sanction, is not very easy. Compliance of Pollution Control Board is a prerequisite for obtaining local body registration, like a panchayat or corporation registration. PCB sanction is mainly concerned about, number one, so many factors, including number one, purification of water before being let out to the atmosphere. You are using water. Where this water will go afterwards? Will it not contaminate the nearby water resources? So it should be purified primarily. Then management of dry waste, which is biodegradable at one side, and management of wet waste, which are biodegradable on the other side. And the third thing, management of non-biodegradable plastic or metallic waste where these things are dumped. So these three: management of dry waste, wet waste, and non-biodegradable waste. So all these things are together. It is a costly procedure, and getting a PCB sanction is not very easy nowadays. After getting PCB sanction alone, you can apply for a local body registration. That is why everything is going costly in such clinics, because lakhs and lakhs one have to shed for getting a PCB sanction. Inspection of the premises and other things by local body people will be there. Local body license is a must for reimbursement also. Not only for reimbursement, if you are running a clinic, license should be there. Otherwise, it is criminal. It is considered criminal. Clinics without license is considered unlawful. Approval of state or central governments may be got, but with difficulty you can get. And still better than that, accreditation by National Accreditation Board, NABH, and healthcare providers of Ayush can also be got. So these are the licentiating steps which you may have to do, the primary of which is PCB itself. Other certificates for reimbursement purposes which you have to give include discharge summary, medical reports, cash bills of investigations and medicines, copies of investigation reports like lab reports, imagology reports, all signed by the doctor concerned, surgeon concerned, the list of the medicines, the discharge bill, receipt of the bill, etc., etc. See, all these things are other certificates. The equipment in your theater. Equipment depends upon what you are doing in your theater. Specific examination and operation tables, related furniture, that is one thing. Storage facilities for storing sterilized goods and non-sterilized goods. Instruments for the procedure. Tailored drugs. Certain drugs you are making your own drugs. For example, Yashtigrada. Yashtigrada you have to make yourself. It is not available in the market. At the same time, Yashtigrada is very important for an anorectal practitioner. Yavedana Shastranivadajada Devaram Shariram Prathinodijanto Kridena Sa Shanti Mobedi Sikta Koshnena Yashti Madhuganyudena. So these drugs, tailored drugs, including Charasotra. It is always better that you make your own Charasotra rather than purchasing Charasotra from somewhere where you don't know how they are making. Then leeches and other biological agents, you can rear your own leeches. Equipment for Agnikarma and Rektamoksha. It is better that you make your own Agnikarma instrument and Rektamoksha instruments. Then modern equipment like ECG machine, 3-parameter monitor, diathermy for coagulation if you are serious at OT, suction apparatus, all these equipment should be there. And other equipments which are not very necessary, but the provision of which are good includes IRC, infrared coagulation machine, oxygen supply, drip stand, radio frequency coagulators, etc. as per your need. This is one of the example of a patient monitoring machine, which is a must in today's clinical setting, which reads the oxygen concentration, ECG, as well as the pulse. So this is a must in today's clinical setting. During my days when I was there in my doing my post graduation, such machines were not there. But now, what is the pulse of the patient? If I shall know when I am doing LOTS procedure, I should know the pulse of the patient. But unfortunately, if I ask the nurse, you just go for the pulse of the patient, she will be putting her finger like this, and God alone knows the value what she is telling is correct or not. But if you have got a machine, you need not ask anybody. It is there. What is the oxygen concentration in the body? It is there. If the patient is going comatose, you can know, and you can control your procedure. So for all these things, a patient monitoring machine is vital. And the personnel who are doing the procedure and who are there to assist the surgeon. The surgeon, preferably a MS Shalya person with adequate experience and adequate aptitude. That aptitude is more important than experience. That passion that I have previously told, that passion should be there in doing the procedure. Then only you can excel. Experience, I have got 32 years of experience. Even after 32 years experience, if I am not better that I was there previously, what good will the experience give you? So aptitude is more important. Passion is more important than experience. Of course, experience also pays you rich dividends. There is no doubt about it. Then assistant can be another Shalya person or a BIMS personnel with adequate experience, and in his or her case also aptitude is a must. And if you have to use modern drugs, there should be the assistance of a MBBS doctor also, because you are not expected to prescribe an allopathic drug. So it is always better to have the help of a MBBS doctor who can be put as an assistant. Then anesthetist should be the, if you are giving any anesthesia other than local anesthesia. Local anesthesia you yourself can give, provided a MBBS doctor is also there for assisting. But if you are giving any other anesthesia like spinal anesthesia or general anesthesia or IV anesthesia, and the service of an anesthetist is necessary. Then nursing staff. To the best of my opinion, the qualification of the nursing staff is not that important than passion and aptitude. If a nursing staff has got enough experience and aptitude, if at all she is not that qualified, it is okay, provided the other people are qualified. Then comes the attendants, the cleaning staff. All those people have got their own good roles in the running of an anorectal clinic. Then comes the administrative people who have to talk with the patients, who have to convince the patients, and accounts personnel and others. So these are the personal backup. Then stationery, all of us know that a proper case sheet should be there. Proper case sheet means proper case sheet relevant to anorectal procedure should be there. It should not be a Panchakarma case sheet or any other case sheet. It should be an anorectal case sheet itself. It is not also a general surgical case sheet. It is a case sheet. It should be a case sheet specifically for anorectal procedures. And all the prerequisites for objective assessment should be there in the stationery. Cameras, if needed, for visual assessment in follow-up. Previously, what it was, now what it is like that. That also is included under stationery. And last thing, automated patients reports. Doctor, I had been here for anorectal examination some 5 years ago. I don't know the date. Can you trace me? If they ask me, I have to, your name? My name is Govind. Govind, I don't remember you. Like that we have to tell if we have not got any automated patients records. Otherwise, if all the records are automated, the moment you type Govind, his name, his register number, when he came, what all was his findings, everything will come. So that is about automation. That is also in, if you start a new anorectal clinic, that you should make your clinic automated. It improves healthcare delivery by better data access, faster data retrieval, higher quality data, and more versatility in data display. It supports decision making, quality assurance activities, and provide clinical reminders to assist in patient care. Mr. Thomas should have arrived today. Why he has not arrived? The name Thomas will come because today's appointments, his name should be there as a reminder. So all this will be set in automated patients records. It increases the hospital efficiency by reducing costs and improving staff productivity. and enhances outcomes rate programs by electronically capturing clinical information for evaluation. All these things are there in the Ayush site also. So here comes the end of my textual presentation. After this, I'll be showing you certain slides of clinical cases. Hemorrhoids, for example. See, I am telling you that this presentation is basically intended for fresh graduates and not for Shalya practitioners or Shalya teachers or anybody else. So this I am showing for the very young generation of just passed out graduates. Hemorrhoids. See, this is a case of third degree hemorrhoids, which you can see at the 11 o'clock position. And this is the instrument which we frequently use, which is called as Barron's technique, with the applicator and with the suction apparatus, by which we are just sucking inside the pile mass and ligating it with the polypropylene ring. This is a photograph of hemorrhoids just after management with suction aided Barron's technique. We do not only Barron's technique but transfixation and ligation also. Transfixation and ligation is a very easy thing to do. If you have not got much machinery, you can do it very easily. And this is one of the reliable. The effects are almost similar to hemorrhoidectomy. So after 2-3 days, you yourself can see in this picture that the mass has regressed and has become blackish in color due to poor blood supply. And if you have got sophisticated machines like high frequency coagulator, this is a Korean coagulator which I was previously using for piles, using bipolar coagulator. This is a good instrument, but not reliable instrument in the management of hemorrhoids. Very costly instrument also. This is a case of thrombosed piles. You yourself can see the thrombus. Thrombus means blood clot, bluish in color. Inside that semi-transparent mucosa, you can see that bluish masses of bluish areas of thrombosis. Then coming to fissure in ano, you can see the fissure nano here. That canopy-shaped ulcer at the posterior or very rarely the anterior midline of the anal canal, which we in Ayurveda call as parikartika. Then this is a ligation treatment which I have introduced for fissure nano. I have published a paper also about the ligation treatment for fissure. Ligating the fissure in its long axis itself with the help of a plain thread ligation, which have given wonderful results than the lateral sphincterotomy, which is a complex procedure and a procedure involving much complications. This is a very ligation treatment is a very simple procedure. And this is about hydradenitis suppurativa. You can see simple cases like this in the axilla, in the both axilla, right and left. It may affect both the males and the females from suffering from hydradenitis. Hydradenitis. Hydra means water, adena means gland, water gland. Water gland means sweat gland. Itis means inflammation. Inflammation of the sweat glands with suppuration. Suppuration means with pus formation. So this is the hydradenitis suppurativa. It's a very simple case. It can be managed by medicines, and very rarely such cases may have to be managed by Charasutra also. But hydradenitis suppurativa may have to be managed by Charasutra, or there are cases of hydradenitis suppurativa which cannot be managed by any systems of medicine even. This can be considered, although this case is is a case of a complex hydradenitis suppurativa, it can be considered in Ayurveda as Shatapanaka Bhagandara. Multiple orifices. Multiple means multiple orifices are there discharging pus day in and day out. This is a case of recurrent mammary sinus. At the left side, you can see a mammary sinus managed by Ksharasutra, and to the right side of another individual after healing. Two separate cases. So the use of Ksharasutra is not restricted to fistula in ano. It can be extended to hidradenitis or rarely in case of mammary sinus also, what I am telling to you. Even it can be extended, the use of Ksharasutra can be extended to pilonidal sinus, pilonidal, pilus means hair, nidus means tuft, pilonidal, a tuft of hair or a bunch of hair. See, this is a case, these are cases of pilonidal sinus, which almost always occur in the region of the skin, in the region of the first piece of the coccyx. And we do apply Ksharasutra and we do cure such complicated cases of pilonidal sinus. Complicated cases of pilonidal sinus means pilonidal sinus is essentially a very simple condition. But the surgery for pilonidal sinus is not very simple. It involves sedplasty and other plastic surgery techniques, which are very quite complicated procedures involving lakhs and lakhs of rupees. But you can manage it with Ksharasutra. Very simple management by Ksharasutra. Or this is a case of pilonidal sinus. You can even see the Ksharasutra in situ. Then so many cases will come to you telling that they have got piles, painful piles, but on examination you can see it's a case of abscess. Such conditions should always be judged by Goodsall's rule. Goodsall's rule should be there in your brain. All of you, I'm sure all of you have by-hearted Goodsall's rule. But simple by heart of Goodsall's rule is not enough. You have to apply the Goodsall's rule. Whenever you see an orifice, oh, this opens internally at this particular point. You have to know by applying the Goodsall's rule. And you have to know that fistula is the resultant of a prior abscess, and that rectal abscess will always lead to a quite large anorectal abscess, or a pelvirectal abscess also will lead to an anorectal fistula. At the same time, a small hello, a small to either a subcutaneous fistula or a submucous fistula only. So, gradation of the fistula in ano in terms of the abscess should also be known, which is mentioned in Ayurveda as apakvam pedagamahu pagapraptam bhagandaram. This is a case of, hello, can you hear me?
Yes, sir. Yes, sir. Sorry for the interruption, sir. Please continue.
This is a perianal abscess in Pakwa Avastha. I think you can see, you can appreciate this perianal abscess here. And you can appreciate these perianal abscesses which are recurrent in nature, occurring at the same site again and again. Whereas this is what is called as an rectal abscess. It is very difficult for you to distinguish between the right and left sides, because this is in very depth of the tissue. Gambhiratvam is a property of kapha, rectal abscess. And there are a variety of fistula which occurs subscrotally. It is collectively called as subscrotal fistula, which in the females occur at the perivaginal region also. The diagnosis and management of fistula, the basic instrument what we have is a probe itself, but the probe is of many types. It may be a copper probe. It may be the copper probes itself may be of varying diameters, and there may be probes made of stainless steel. There may be probes with a tip at the opening at the tip here, and here you can see the opening rather than here at the tail end. And this is, as you can know from the slide, this is a probe made of silver. Silver means silver has got malleability, much more than stainless steel. So many types of probes for many types of purposes. See, not only that, you should apply your head when an opening is there at this side and there is an opening seen at the other side. You should know that these two openings are communicating through the inside of the body. You can send the patient to a MRI fistulogram, which costs approximately some 10,000 rupees. But in this particular case, I have chosen to apply a simple syringe with jelly. If you push the jelly through the one opening and the jelly comes through the another opening at the another side, you can yourself know that there is a communication, and that this type of fistula with communication from one end to the other side is called as a horseshoe fistula, like the shoe of a horse. And then these are various levels of application of Charasutra in low level fistula, or types of application. This is called as the cobbler technique. Cobbler technique means, cobbler means one who repairs our shoes and all. The needle which the cobblers use is similar to what I am using here, so that this is called as the cobbler's technique of putting Charasutra. Anyhow, relatively it's a simple technique, provided the fistula is a lower level variety. But if it is a high level variety, it's a complex procedure. This is a high level fistula, which in Ayurveda is called as Unmargi Bhagandara, Unmatta Margam Unmargam, Unmargam, high level, very high level, Unmargi Bhagandara. And here also, this is a very rare case of fistula. This I have done around 30 years ago. I don't know whether the individual is living now also. At that time, he was a youngster of some 19 years or 20 years. You can see the external opening below the buttocks at the upper end of the thigh, the patient. So it was managed so that the whole buttock had to be cut by means of Charasutra. It is a very difficult technique, very painful technique. But the patient went through the agony of those technique in those times, and then you can see that it is completely healed. And then high level fistula itself comes with a very large tracts, the lengthy tracts. And this is one such a case. You can see the opening here, and after management with Charasutra, you can see. See, this is still another case with 3 different tracts in a same individual. All the 3 different tracts in the same level, side itself, left side of the anal verge. So one by one, the 3 tracts were managed by Charasutra, and this is the penultimate picture, because the last picture I have not got. The picture just before all the treatment has, all the tracts have healed. Here a little bit of healing is also to be done. So this is the management. Total management took about 4 months. So one fine sunny evening, I'll tell, somebody called me from America stating that they are managing one fistula there, and it's almost 6 months after the management, and the patient has not got any relief. Initially stating that the patient had only, he was a Malayali of Thrissur origin, settled in America, and he told that initially only one opening was there, but now he has got 3 openings, and shall I come and manage? The patient was invited to come over here, and to my surprise, I was seeing this the first time. Something which later I knew that it was a drainage seton made of some rubbery material put there, And there was 3 openings, here one, and in the midline one. And later I removed all these things and managed all these tracks by simple Charasotra. And at the end of some 2 months or 2.5 months, the entire tracks were healed and the patient was completely okay and went to his workplace. This is another case. In order to reduce the cutting time, we use coagulators, modern instruments, to cut after the Charasotra has placed. The skin and the subcutaneous tissue alone will be cut by coagulator. So this is such a case. We manage such cases by Charasotra plus another technique, a modern technique. So together, such techniques are called as hybrid techniques. Hybridization. Hybridization means one ancient technique and one modern technique put together in the same individual, in the same in the management of the same tract, in order to reduce the cutting time. So this is one such case after the wound of one such case after management by hybrid technique, initially by Charasotra and followed by high frequency coagulator we applied. After application, once the track was laid open, we apply a plug with Jatyadi Ghruda. This is another J-shaped wound, J-shaped fistula in ano, subsequently managed with a hybrid technique. This is a picture of a perivaginal fistula after being opened by hybrid technique. This is also a technique in evolution. Partial cutting by Charasotra and partial cutting by high frequency coagulation was done, but yet the muscular portion is managed by Charasotra alone, so that it will take still more time. So this is a various management techniques which we follow in high frequency coagulation is essentially an Agnikarma. Though we use a modern instrument, the concept of the technique is similar to Agnikarma in low level fistula after 3 days of Charasotra. Some cases of Charasotra, post Charasotra cases, develop a hypergranulation tissue. So such hypergranulation tissue results in poor healing. So in order to remove that hypergranulation tissue, we use Charapadanam, Pratisarana Charam for faster healing. These are the steps of Charapadana in cases of slowly healing post Charasotra wounds for debridement. After healing also, we will ask the patient to report every week, and later once in every 2 weeks, and still later once a week, like that. This is for ensuring that the healing is proper and no fresh tracks are there. So post-operative follow-up is also an essential prerequisite of an anorectal clinic. This is another high-level fistula in mano after management. You can see the scars. You can see an ulcer and a scar at the right, left and right. You can see here a high-level horseshoe fistula at the left side and at the right side with scar after healing. And this is another scar after Charasotra treatment in a supralevator type of fistula, which is a very complex type of fistula. 2 months, 3 months, sometimes 4 months treatment. This is a scar left after management of a high-level anterior fistula in ano. After management of a complex recurrent high-level fistula in ano, you can see the scar here in a subscrotal fistula, the scar. See, only a very thin linear scar is there. See, this patient has come after fistulectomy. You can see that here there is an opening and here also there is an opening. And here possibly there should be another opening. So this is the end result of most fistulectomy cases. It is very rare that a fistula is completely cured for life by fistulectomy. There is every chance that it might recur. Here also, if you closely observe, you can see a small opening. You can see the very large scar of fistulectomy and an opening of recurrence. So, coming to the end of my presentation, I have already introduced a variety of equipment and a variety of instruments, and you have seen some telltale photographs of cases before healing and after healing. But if you ask me, what is the ultimate equipment that a clinician shall have? I'll tell you that respectful memories of teachers and of what they have taught, which we call Gurutva, is the ultimate equipment that a clinician should have. This does not mean that students should copy their teachers. They should not copy their teachers. In their minds, they should always question their teachers. At the same time, they should pay respectful regards to their teachers in their minds. This does not also mean that teachers are always correct. Teachers can be wrong because they too are humans. But let them be wrong. What is there? They have showed the delicacy to teach you. So that respectful memories, what I keep even now, that should be there. And what I am to tell last but not least is that students should pave their own ways and methods for their future, which should be unique in their respective fields. This does not reflect upon anorectal clinic only. Whether you be a Kajilsa practitioner or a Panchakarma specialist or a Shalakya specialist, whatever it be, Prasudi Tantra specialist, whatever it be. This is very important. Memories and respect to your teachers. It's a must. And I do consider that this is the ultimate equipment that a clinician shall have. So thank you for patient hearing for about 1.5 or 3/4 of an hour. Thank you very much.
Thank you, sir. Thank you very much. It was a fresh breath of air. You managed to mention all the aspects of a clinical practice in a nutshell, including the very subtle areas which everyone usually omits. And I'm sure that the students should be very much benefited through your words. And I'm sure that your words should have instilled a sense of confidence in them. Now, the session is open for discussions. You can either post your queries in the chat box, or you may directly raise your questions by unmuting yourself. Sir?
Can somebody type the question so that I can see the question? It's not very clear.
No, sir, I can read it out for you, sir. So we have got one query. May I ask you, sir? Sir?
Yeah.
Yes, sir. So we have got one query about whether you could mention about a few medicines which can be used for an emergency treatment, as a part of emergency management,
The
sir.
question is not very clear to me.
So the question is whether you could mention some medicines for emergency management, maybe as a part of a complication of a procedure or otherwise.
Certain our medicines are there, which can be used in emergency, like Yashti Gruda, For immediate pain relief after a post-operative sequel of pain, you can use Ashtamgam. In many other conditions, you may have to use allopathic medicines. For what I have told that the service of a MBBS doctor is also better when you are running an anorectal clinic. Have my answer to be very specific? I cannot even get the idea of the question. The usage of emergency medicines in complications, no?
Yes, sir.
That
Yes,
is what
as
I am telling. The usual complications are pain and hemorrhage. Hemorrhage you can manage by our own techniques, usually. We need not use any allopathic medicines. But regarding pain management, if it is immediate post-operative pain, we can use our medicines. But if it is a chronic pain, as happens in Charasutra, you may have to use allopathic medicines. These allopathic medicines and sitz bath can also be used. Any severe pain, if you sit down in warm water, immediately the pain will be relieved. But the issue is that after getting up from the water, again you will be having pain. So, in order to control pain for 1 hour, 2 hours like that, you have to use allopathic medicines. Ayurvedic medicines will not work in such conditions. Dr. Ashwati was asking now that for bleeding internal piles, are aristas complicated? Usually, we will not give any aristas. Why? Because the students have to judge themselves. Because in anorectal conditions, what happens is that majority of the conditions acidity will be there. Acidity will be an inherent issue with most of the anorectal conditions. And aristas, whichever aristas it be, even if it is see for example Pudi Karanjasava or Pudi Valkasava, indicated specifically for acidity. Generally, aristas have got the issue that it will increase acidity. So we generally will not prescribe any aristas in anorectal conditions. Whether it increases bleeding, chances of bleeding, Abhayarishta, Ashwati again is asking whether Abhayarishta helps. Abhayarishta helps in chronic conditions, but not in the immediate post-operative conditions. Immediately in the post-operative condition, I will not advise anybody to prescribe aristas or asavas. It may invoke complications, not bleeding, but acidity and related complications. So aristas are better avoided during the post-operative period. Is there any other question?
Yes, sir. We have another question. Is that if we have recently started an anorectal clinic, and if by chance by examination we are discovering that it is actually a colorectal cancer, what would be the apt method that we could do? Where either we could refer the patient, or should we try to attempt the treatment according to the knowledge that we have?
Can you type the question in the chat and show me?
Okay, I will ask the person who has posted to please say it out to you, sir. Could you please type it commonly into the chat box? Sir, there is another query in the meanwhile, sir. May I ask you, sir? So, if by any chance, in a case of fistula in ano, if there is no internal opening developed, whether we should create a false one or should we wait? What may be the healing time if we create a false one? Sir?
One minute. Let me go through the chats.
Yes, sir. It has been posted by Dr. Ashik Narayan.
If there is no internal opening developed, whether we should create a false one or wait. What may be the
Yes.
healing time if we create a false one? This was a question posed to Ashik Narayan. Okay, I will answer. If there is no internal opening, what we are doing is we are putting the probe through the external opening and trying to gauge whether, if at all there is any internal opening, how we can know whether there is any internal opening or not. Primarily, it is not probing which should be done. What I feel, what I am using is that externally through the external opening, I will infiltrate jelly inside, sterilized jelly. When the sterilized jelly is forcibly introduced through the external orifice, if there is anywhere an internal opening, you can see that the jelly is protruding through the anal verge if there is an internal opening. If there is no internal opening, you cannot further push it. In such instances, we will take out the jelly and we will put the probe and put the other finger in other side finger inside. And if we can palpate the probe, you can very well open it up. But at the same time, if you cannot palpate the probe, it is there is very gap difference between the site of the probe and your finger. It is not advisable to pierce such a thickness of the anal or rectal wall. So you should not pierce it. At the same time, you can apply medicines internally and through the tract and wait for the internal opening to develop. But if it is palpable, the tip of the probe is palpable, you can very well take it out, create an internal opening there itself and take it out. And how much the healing time depends upon what level the fistula is. If it is a very low level fistula, you can manage it very easily. Very easily means within the course of 2 weeks or 3 weeks. But at the same time, if it is a very high level fistula, you may be able to manage it within 3 months or 4 months only. So that is what my answer is with regards to the question posed by Dr. Ashik Narayan. And Dr. Ashwati again has asked, could you suggest some medicines? Medicines for what? Medicines for what? I don't know. Medicines for what? She hasn't written. I just started an anorectal clinic, Kiran B. Raj. If I just started an anorectal clinic, and if a colorectal cancer patient comes to my clinic and by examination I diagnosed it as colorectal cancer, should I refer or treat by the basic knowledge I have got? Very good. This is a question which is very interesting. See, Dr. Kiran, if you start a clinic and if you have diagnosed a colorectal cancer, possibly a rectal cancer, because colonic cancer is very difficult to diagnose by the facility we have at our anorectal clinics. You may have to do colonoscopy, etc. But if by digital examination or by introducing proctoscopy itself, you have diagnosed a case of malignancy, it is very okay that you should take a specimen from there for histopathological examination, load it in formaldehyde, send it for histopathological examination, and when the results are got, if it is confirmed that it is a malignant case, you should refer that case immediately to an oncologist, or a surgeon. You should not manage it yourself, by no means at that time, because I'm not telling that they are much better than us. In many cases, they are much worse than us. But at the same time, if any chance is there, any ray of hope is there to the patient, it should be utilized. If then where is our role in management of cancer? Our role in management of cancer is for the very poor patients, very destitute patients who have not got anywhere to go. They will come to us stating that, doctor, I have not got anywhere else to go. I am at your disposal. You can do anything. See, please. Like that, if a patient comes to you, you should manage such case, because all the managements, nobody can do anything. Then why don't you do something, and why don't you prove your mettle? That is where that you have to act. And it is not that in the initial stages itself, your role as a diagnostician is proved already. It is you who have diagnosed the case and nobody else. You still have a good chance to be on the stage, but you may not be able to manage that case. So it is always better that you manage that you refer the case after diagnosis. You manage the case, you refer the case to some good surgeon or a good radiotherapist or a good oncologist. Okay, then any other questions?
Yes, sir. There are a few.
In a case of pilonidal sinus, how can we put a Charasutra in the cases of single opening? You have to make another opening, there is no doubt about it. In pilonidal sinus also, even if there is no guideline as a Goodsall's rule, by the anatomy, that is why I told you, anatomy is always the primary consideration of a surgeon. Your knowledge of anatomy should be that what do you call that superb. Then you know that this tracks goes this side only. It goes in the midline only usually. Very rarely only it goes to the laterally. So whether it goes higher up or lower, that you have to examine by your probe, and you can easily find out whether it goes caudally or distally. And then you can put your probe and you can open up where it ends, and then through that track you can tie your Charasutra, and you can manage it 100% successfully. You can manage in a case of pilonidal sinus. It may take time, but management of pilonidal sinus by Charasutra is the cherished method what we can do. Sir, whether we can, the next question is by Dr. Remya. Sir, whether we can use sterile water instead of jelly in fistula and ano. Is there any difference? You can use sterilized water also, but the thing is that jelly is better, because jelly has got what I call, if you instill water, there is every likelihood that the water will spill very easily. Rather than instilling alcohol or water, it is always better that you instill jelly. What I feel, that is what I am doing at least. Then the next question is by Dr. Rajalakshmi. What are the pathyas to be followed by a patient with fissure in ano, both ahara and vihara? This is also a very good question. Very good question in the sense, what is, for that purpose, for answering that question, we have to understand what is fissure in ano. What is fissure in ano? Fissure in ano is a mana sharira batha. Means the roots of fissure in ano are there in the mind also. It is not 100% disease of the body. It can be considered as a psychosomatic disease even. Number one. Number two, coming to doshas, it has got vata pitta predominance. So if you are managing with pathyas or even with medicines, in a case of fissure in ano, you have to manage it in terms of saumya ahara vihara. Means it is vata vaitika. Because it is vata vaitika, you have to use saumya ahara vihara, like ghee, like milk, like that. Such ahara vihara you have to use, like moong dal, that is green gram, like shashtigana, things like that you have to use, like ashgard, that is Kushmanda Vata Pittaha, because this is a Vata Pittika disease. So you have to use everything which are against Vata Pitta. So Vata Pitta Hara Kushmanda you can use. All the Vata Pitta Hara foods you can use. Such things will be better. You have to first of all understand what it is, and you have to educate the patient. In such conditions, education is very important. In diseases of the mind, education of the patient with regards to what the patient's disease is, we have to educate the patient. When the education is complete, this is the cause of the disease. Okay. So the patient is put at ease with their management. So I think that I have satisfactorily answered Dr. Rajalakshmi's question. The next question is by Dr. Kavya. In a newborn with a pseudo membrane closing the anal opening, any Ayurvedic management helps? I mean, any medications can be used. It will automatically open up. If not opening up, you can use a dilator, small dilator, or even you can use your own little digit for opening it up, or any slightly sharp instruments you can use. That is not a problem if it is a pseudomembrane. It is very easy procedure. Then Dr. Shubham Kumar, my connection is lost. I cannot maintain a connection. So Dr. Sharmita Sinhe wants to ask, after surgery of hemorrhoid, is there any chance of reoccurring? This is also seemingly a good question. And any management further for complete cure? See, what is the management protocol of hemorrhoid? Means Arsharoga. It is mentioned in our science. 4 types of Chaturvidham, Yatharsha Samsadhanopaya, Tadyatha, Peshaja, Kshara, Vannihi, Shastram. All these 4 methods are there. So why it is mentioned like that means even these 4 management protocols are not self-sufficient. In issues, in instances where hemorrhoid is not completely manageable by the procedure, whatever procedure you are doing, there is a chance for recurrence. But to the best of my experience, recurrence in hemorrhoids is very less, provided that you manage the case after dilatation, after dilatation. After Lord's procedure, if you are managing the case, recurrence is very less. And you have to, of course, you have to educate the patient that after the procedure, alcohol consumption is totally banned, and food which are very rich in what I call Katu Rasa Ahara Pradhana and Katu Amla Rasa Pradhana Ahara should be avoided, fried articles should be avoided, and plenty of vegetables should be taken, especially this buttermilk shall be taken in plenty, onion shall be taken in plenty, yam should be taken in plenty. If you are following such pathyas in hemorrhoid, even after the surgery, I think if the pathya is accurately followed, hemorrhoid will never recur. In my instance, I am getting very less hemorrhoidal recurrences. I am managing at least 1,200, 1,300 cases per year, hemorrhoids. But I am getting only one or even one case itself very rarely only as recurrence, because I am very strict in post-operative follow-up, and I am very strict in advising them the pathyas and apatyas which the patient shall and shall not use after the procedure. So many of them are following it, and it is very rarely that a hemorrhoid recur after my procedure. I'm not telling that it is 100% cure or things like that, because if it is genetically determined, sarve roga kulolbhava. But chances to recurrence are very rare. Are there any more questions? I think seemingly
No, sir. I think we have reached the end of the question answer session. So maybe we can move ahead. Next, on behalf of the Ashtamgam Vidyapeedham and Vidyapeedham and Department of Salyatantra, so we would like to present you a token of appreciation through this e-certificate, sir.
Okay.
Thank you, sir. Next, I invite Chaitanya for the vote of thanks. Chaitanya?
Hello, ma'am. Am I audible?
Yes. Yeah, you are audible.
Honorable resource person, respected teachers, organizing committee, delegates, and my dear friends. A warm good evening to one and all. It's my privilege to propose vote of thanks on the closure of this second session of Sastrasiddhi 2020 National Level Webinar Series organized by Department of Salyatantra, Ashtamgam Vidyapeedham, Evam Chikitsalayam. I, Chaitanya Janaya, on behalf of Ashtamgam Vidyapeedham and entire fraternity of the institution, first of all like to thank Almighty God for making today's event a great success. I would like to extend my most sincere thanks to Dr. T. Sreekumar sir, Professor and HOD Salyatantra, PNNM Ayurveda Medical College, who spared time from his busiest schedule for enlightening us. It was indeed a knowledgeable section on opening up an anorectal clinic. Thank you, sir. Thank you for your very informative session. Also, I would like to extend my extreme gratitude to our Salyatantra department. I thank Vaidya Purushottaman sir, Superintendent and HOD of Department of Salyatantra, Ashtamgam Vidyapeedham, and Vaidya Jyotsna ma'am, Assistant Professor of Department of Salyatantram, Ashtangam Ayurveda Chikitsalayam, for providing us such a great opportunity. I would like to thank Vaidya Rahul sir for his valuable felicitation speech. I would like to thank Devika Rajan, final year student, for reciting the prayer. I would also like to thank Shruti P, final year student, for the welcome speech. Last but not the least, I would like to thank all the delegates and all dear friends for your keen participation, which made this event a resounding success. Thank you all.
Thank you, Chaitanya. And thank you, respected sir, for the wonderful session. Next, a general reminder. Kindly fill the feedback form, those who have not filled as yet, and submit them. All the participants who have attended more than 3 sessions in this series and have also duly filled and sent the form will be provided with an e-certificate. And about tomorrow's session, we have Dr. Rishikesh OK, Assistant Professor, Department of Ayurveda Samhita and Siddhanta, JSS Ayurveda Medical College, Mysuru, with us tomorrow. He will be dealing with the topic influence of darshanas in Susra Samhita with special reference to Salyatantra. Again, thanking all and wishing you all a very great day ahead. Thank you. Thank you very much.